Resham, we can start in two, three, one.
Good afternoon, ladies and gentlemen. On behalf of IHW Council, I welcome all of you to the session as a part of Breast Cancer Awareness Series supported by Roche. I'm your host, Resham Shankadar, and today we'll be discussing about decoding genetics, that is, understanding the link between genetics and breast cancer risk. And it's my absolute pleasure to have Dr. Monica Bopana, who's a consultant medical oncologist at Kim's Hospital. So, firstly, ma'am, I welcome you to the discussion and thank you for connecting with us.
Thank you very much for giving me this opportunity.
Okay, so ma'am, starting straight with the first question, which is how does genetics play a role in determining an individual risk for breast cancer?
Yeah. So we know that DNA damage is the underlying basis of all cancers. Our DNA carries the genetic code, which controls everything about our body, the way it looks, the skin color, the hair, the functioning of the various organ systems in our body. Everything is controlled by the genetic code, which is there in the DNA. Now, our DNA is constantly being damaged by various agents, which could include chemicals, hormonal imbalances, physical agents like radiation, infections. All these agents are continually damaging DNA. If left unrepaired, this DNA damage can accumulate over a period of time and it can lead to cancer. Fortunately, this doesn't happen because normally this doesn't happen because our body has a lot of DNA repair mechanisms by which it's constantly repairing this DNA damage, and it is able to remove the defective DNA, and it is able to resynthesize and insert the right genetic code or the sequence. So this is a multi-step process. DNA repair, which is constantly happening in our body, it's a complex multi-step process, and several genes are involved in this process. And this intricately orchestrated DNA repair process it needs to happen very smoothly, and only if all the genes are functioning properly, all the genes which are involved in DNA repair are functioning properly, only then it can happen smoothly. If any one or more of these genes involved in DNA repair are defective or not functioning properly, then the DNA damage does not happen. The DNA damage tends to accumulate over a period of time, and finally, it would result in uncontrolled and unnecessary multiplication of cells, which causes cancer. So, some people, some individuals, they carry a birth defect in one or more of these DNA repair genes. Such individuals are said to have a germline defect in the DNA repair mechanism. Now, these individuals would be at a much higher risk of developing breast cancer as well as certain other cancers like ovarian cancer, pancreatic cancer, or colon cancer, depending on which DNA repair genes are affected. So that is what formed the genetic basis of breast cancer, the hereditary genetic basis of breast cancer. These individuals are at a much higher risk. And that's how it is so important in determining an individual's risk of breast cancer, that is doing a genetic analysis of their genes.
Okay. So, with that, can you also explain the significance of genetic testing in accessing breast cancer risk?
Yes. So, as I said, there are multiple genes which are involved in DNA repair, damaged DNA repair normally. And most of you might have heard there are two very important genes which we commonly hear about or talk about. They are called as BRCA1 and BRCA2 genes. So these genes are very, very important. They play a crucial role in one particular method of DNA repair pathway. So defects or mutations, what we call as mutations, mutation is a damaged gene. And if there are defects or mutations in these genes, they are associated with a higher risk of breast and ovarian cancer and some other cancers as well, like prostate cancer and pancreatic cancer. So these two genes together, they are called as the hereditary breast and ovarian cancer genes. So by testing for defects in these genes, we will be able to assess whether a particular individual is at a higher hereditarily driven risk of developing breast cancer. Now, this testing can be done on blood samples as well as the cheek swab samples. That is, a swab is taken and the inner lining of the cheek is just scraped with the swab, and the cells which come onto the swab, the DNA is extracted from the cheek lining cells, and then the genetic analysis can be done. So we can assess, by doing this, we can assess whether a person carries a birth defect in these two important DNA repair genes, that's BRCA1 and BRCA2. Now, if a person has a germline BRCA mutation, it means that this individual, every cell in this individual's body will be having this defect. And they can pass it on to the next generation also. So that's why it's called as germline, because every cell in the body will have a defective DNA repair mechanism. Now, if a defect is actually detected, then we can say that this person is at a much heightened risk of developing breast cancer as compared to the general population. Now, genetic testing is very important in breast cancer for many reasons. One is we can know whether this individual is at a risk of developing cancer in the other breast as well. If the person has already developed cancer in one breast, we would know what is the risk of this individual developing a cancer in the opposite breast. And we would also know whether it's a hereditarily driven breast cancer. That means, is there a chance that the first degree relatives of this patient, that is the patient's children and the patient's siblings, can they also have an increased risk of breast cancer? Do they also get or carry these mutations? And also whether this patient is also at a risk of developing other cancers like ovarian cancer, pancreatic cancer. So we will be able to address and analyze all these risks. We will be able to objectively quantify the risk for the patient and then formulate treatment plans for them. We can also plan risk reduction strategies, like we can formulate plans in order to reduce their risk of breast cancer. Like we can offer surgical removal of both the breasts and both the ovaries for such patients who have been detected to have germline BRCA mutation. And even in the family members, all the family members, whoever have been detected to have this particular genetic defect, who are at a higher risk of developing cancers in the future, we can start screening for them at a younger age, at a much younger age. And also we can counsel them to be more aware that they will be at a higher risk of developing certain cancers. So regular breast self-examination is very important, and to report to us any symptoms pertaining to the cancers for which these individuals become more susceptible. So that way, genetic assessment becomes very important in assessing an individual's not only breast cancer risk, but also the risk of developing other associated cancers.
Okay. So, ma'am, with that, what specific genetic factors are commonly associated with an increased risk of breast cancer?
Right. So as I said, BRCA1 and BRCA2 are the two most commonly implicated genes in hereditary breast cancer. So whenever we say genetic risk of breast cancer, by default, we are mainly talking about these two genes because they are the most common ones which are implicated. And together, these two genes are called as the hereditary breast and ovarian cancer genes. But sometimes, even if BRCA1, BRCA2 genes are structurally and functionally normal, means there is no mutation, no harmful variant in them, and they're functioning normally, still there may be defects in other genes which are involved in DNA repair or tumor suppression function. BRCA1, BRCA2 are only two of the multiple genes which are involved in DNA repair. So it's not enough if just these two genes are functioning normally. The other genes also have to function normally. So even if BRCA1, BRCA2 are absolutely normal, if there are defects in other genes which are involved in DNA repair or tumor suppressor function, then that person would still have an increased risk of breast cancer. So there are some other such genes such as P10, P53, PALB2, CHEK2, ATM. These are just to name a few of the other DNA repair and tumor suppressor genes whose germline defects can lead to a heightened susceptibility to develop cancer. But however, the mutations or defects in these other genes are relatively rare as compared to the defects in BRCA1 and BRCA2. Now, the risk of developing breast cancer during the lifetime of a woman in the general population, in general, if you ask what is the risk of developing breast cancer, if you just keep the genetic factor aside, it's about 15%. So 15% of the women today, at any given point of time during their life, can develop breast cancer. Whereas the risk in a person who has a harmful BRCA1 variant is as high as 55 to 70% by the time they reach their 70s or 80s. And the risk is as high as 45 to 70% in an individual who has a defect in the or a harmful variant of BRCA2 gene. So it's 55 to 70% lifetime risk of developing breast cancer for a person with a harmful BRCA1 gene variant, and 45 to 70% for a person with a harmful BRCA2 gene variant. So, of course, this risk in any one individual woman is also controlled by so many other factors other than genetic factors. And these factors are quite highly variable. That's why if you see about 30 to 40% of the individuals who do have harmful BRCA variants, they may still never develop breast cancer during their lifetime, because development of cancer is a complex interplay of multiple factors like genetic factors, hormonal factors, exposure to external cancer causing agents or carcinogens. There are so many other factors which will finally they play together and they culminate in the development of cancer. And the presence of any one factor alone may not actually be enough to cause cancer. So in a person who has a genetic susceptibility for breast cancer because of any of these gene defects, if other factors also get added, like a high estrogen level or exposure to tobacco related carcinogens and things like that, then they will have a much higher risk of developing cancer. So that is how these are the genes. These are the specific genetic factors. Mainly what we talk about are BRCA1, BRCA2 genes, but there are other DNA repair and tumor suppressor genes also whose defects can increase the risk of development of breast cancer in an individual.
Okay. So now like we should talk about the cure as well. So are there any lifestyle modifications that individual with a genetic predisposition can adopt to reduce this risk?
Right. As I said earlier, the presence of a genetic defect is not enough to cause cancer. There are other factors also.
Yeah.
So the genetic or hereditarily driven factors are not really under our control, right? We really cannot do much to modify them, and they don't change with treatment. They are always there. If a person has a germline defect in a particular DNA repair gene, that person has to live with that defect throughout his or her life. But there are many other modifiable factors. And among the modifiable factors for breast cancer, the most important factor is reducing the exposure to estrogen, which could be external estrogens or it could be estrogen in the body. Now, obesity is directly linked to the higher risk of development of breast cancer because obesity is associated with a high estrogen level in the body. So, maintaining an ideal body weight by regular physical exercise and minimizing the consumption of foods which are high in refined carbohydrates or fats will help us in maintaining an ideal body weight, and that will reduce the estrogen level or it will minimize the high estrogen exposure in our body. Extrinsic estrogens in the form of hormone replacement therapy, which was very popular at one point of time in postmenopausal women, but they realized that it was associated with a very high risk of developing breast cancer, and hence it's gone out of use nowadays. But women do take estrogen in the form of estrogen containing oral contraceptive pills. If they have used these pills for a long time, like 5 years or longer than that, then that increases their risk of developing breast cancer during their lifetime. So, minimizing the use of hormone containing oral contraceptive pills and switching to non hormonal contraceptive methods also helps. Similarly, just like for many other cancers, tobacco smoking is a risk factor for breast cancer as well. So, women who smoke, they're definitely at a higher risk of developing breast cancer. So, smoking cessation also becomes an important intervention. Whatever I've just told, they are general blanket interventions, risk reduction strategies for everybody, not just those who have a genetic defect. But because those who have a genetic defect, they are at a much higher risk of developing breast cancer. We can minimize their risk, or we can at least to some extent reduce their risk by controlling all these factors which are actually under our control.
Okay. So, ma'am, with that, how does genetic counseling contribute to the understanding and management of breast cancer?
Yes. Once we have a report that says that a person is genetically at an increased risk of developing breast cancer, the first thing we do is refer them to a genetic counselor if available in the institution. But this genetic counseling plays a very important role in making the individuals understand the actual meaning and implications of the test report, because many individuals, once they see this report, they have a lot of questions. Women do ask us, can my cancer ever be cured because I have this genetic defect? Will I for sure get back this cancer and die of this cancer finally? Will I develop cancer in other parts of my body, other organs? And because of this genetic defect, will my children and siblings also have an increased risk of cancer? Would they definitely have inherited this defect from me? And should they also be tested? When should they be tested? When should screening be done for them? So that way, they have a lot of questions in their mind once they see this report. And it's important to involve the genetic counselor from the beginning. Usually, we sit together, the oncologists usually sit together with the genetic counselor and counsel the patient as a team. If a woman has a germline BRCA mutation, there is a 50% chance that she would pass it on to her children. And hence, at an appropriate time, it is very important to do the genetic testing for the children as well. And similarly, siblings also may be carrying this defect. So siblings also have to be tested. All family members who have been tested positive for a pathogenic, that means a harmful BRCA variant, they have to be counseled about risk reduction strategies, means how can we reduce their risk of developing breast cancer. So we can offer prophylactic, that is preventive removal, surgical removal of both breasts and ovaries. And also there are strategies like chemoprophylaxis where some tablets can be given, some hormonal tablets can be given in order to reduce the risk of breast cancer. Lifestyle modifications can be taught to them. And usually screening has to start a decade earlier in the family members, especially the children. Breast cancer screening has to be started a decade earlier than the age at which the parent has developed a breast cancer. So if a mother has developed breast cancer at, say, for example, 45 years of age, and she's found to have a germline BRCA mutation, then her child, her female child, has to start screening mammographies or MRI of the breast from the age of 35. So 1 decade earlier, we need to start screening the children from the age at which the patient has developed. So regarding all these things, a combined counseling as a team between the oncologist and the genetic counselor, both of them have to sit together and counsel the patient. And then it's important treatment wise also, we take important decisions like whether we kind of discourage breast conservative surgery where only the lump is removed and the breast is kept in women who have BRCA mutation. Although it's not an absolute contraindication, we generally discourage them, and we strongly recommend to go for a complete removal of the breast and also removing the opposite breast. And then there are some medication which can be given for women who have a defect in the BRCA genes. There are tablets which can be given for about a year after completing their cancer treatment. For about a year, they have to take this tablet in order to reduce their risk of recurrence. So that way, genetic counseling contributes a lot to understanding and managing breast cancer risk, not only in that individual, but also in his or her family members. So that way, it is very important. It forms a very important part of our regular management of patients who have a genetic defect.
Okay. So, ma'am, like you mentioned that you recommend complete removal of the breast and not just the lump. So, why is that so?
Yeah, because these individuals are at a much higher risk of developing breast cancer and recurrent breast cancers also in the future, because they have a genetic defect which is affecting their DNA repair, right? So if you leave any breast tissue behind, and already there is a tendency to develop breast cancer in them, there is a very high chance that in that same breast, the patient may have a recurrence. But as I said, this is not an absolute rule that you have to remove the breast. It depends on how much the patient is able to understand that even if she goes for breast conservation, she needs to be under very stringent surveillance and follow up with us. Every 3 monthly, we have to do a physical examination in her. Every 6 monthly, we get ultrasound of the breast, and annual mammographies become compulsory in them. And if the patient is educated enough and motivated enough to understand all this and how important this follow up is, we can go for breast conservation even in women who have a germline BRCA mutation. But suppose the woman is not so educated or not so motivated to keep coming for frequent follow-ups, then we would strongly recommend removal of the breast, because such a woman, she gets the treatment done for breast cancer, she goes away. You don't know, she might just come to us 2-3 years later without coming for any follow-ups in between, and she might just come 2-3 years later with a stage 4 breast cancer because she's developed cancer either in the opposite breast or the same breast, because we left breast tissue behind, we didn't remove the breast tissue. So that's why it depends on the kind of patient who's sitting in front of us also, how educated they are, how motivated they are to be compliant with our follow-up plan. And then we take the decision whether to offer removal of both the breasts or whether to offer a breast conservative surgery. We decide based on that.
Okay. So, ma'am, like we discussed about the treatment strategies and you like told us about it. So, what advancements have been made in decoding the genetic components of breast cancer in recent researches?
Identification of BRCA1, BRCA2 genes, what is their normal function, and what are the implications of a harmful variation or dysfunction of these genes was probably the earliest step towards identifying the genetic basis of breast cancer. Now, following the discovery of the BRCA genes, so much research went into identifying other genes that could be involved in increasing the risk of breast cancer in one way or the other. And as I said earlier, I had named other genes also like P10, P53, PALB2, CHEK2, ATM. These are the other genes. Most of them have a role in DNA repair. Some of them work as tumor suppressors. They are involved in subcellular pathways that control cell multiplication and cell growth. And when they don't function properly, there is uncontrolled multiplication and growth of cells. Genetic component of breast cancer is not just some inheritable genetic defect, gene defect. It could also mean defect which is only present in the cancer cells and not present in other cells of the body. As I said earlier, when we say germline defect, it means every cell in that individual's body will have that defect. But here, the defect may be present only in the tumor tissue. They are called as somatic defects, like the same BRCA1, BRCA2 genes may be mutated only in the tumor and they may be normally functioning in other cells of that patient's body, the normal tissue in the patient's body. Now, such patients, the implications are that whatever medication we use for BRCA mutated tumors, they'll work in these patients because the tumor is having the mutation. But the same implications that a hereditarily or a germline BRCA defect would have, that would not be there for this patient. As in, this patient would not be at an increased risk of developing cancer in the opposite breast. This patient would not be at an increased risk of developing ovarian cancer during her lifetime. And her family members, her children and siblings also would not have this defect. They cannot pass on this defect because it's present only in the tumor. It's not present in every cell of the body. So these are also genetic defects in the tumor. It need not just be germline. It may be somatic also. So basically, this kind of genetic information, it helps us to choose therapies also. And which therapies will work well in the tumors with these genetic defects. We have a lot of gene or molecularly targeted therapies which are in use nowadays in oncology. And those drugs, so these analyzing the genes of the tumor, it will help us choose these kind of therapies. And the technology that we use to detect these genetic defects also has evolved over time. Earlier, we were using something called as polymerase chain reaction or PCR and Sanger sequencing in order to sequence and study the genes and see if they have any defects. Now we are using techniques like next generation sequencing on high throughput platforms. So this is called as NGS or next generation sequencing, which is a much more sensitive technique because even the slightest defect it will be able to catch. We can work with very little DNA. That is another big advantage of NGS. And ever since NGS has come to the forefront of genetic testing, a multitude of genes have been identified that have implications in dictating the biologic behavior of a tumor and the therapies to which it is likely to respond. Now, earlier unknown gene mutations have become well known to us thanks to these technological advances. And these genetic defects, they could be inherited defects or they could be somatic present in the tumor tissue only, but they help us in predicting how aggressive this tumor is going to be and what kind of molecularly targeted therapies would work best for this tumor.
Okay. So, ma'am, with that, for individuals with a family of history of breast cancer, how often should they get this genetic testing?
Yeah, so if for the who should get the genetic testing done is a more important question because that means it's not like a so this is not like a routine blood test. It's not like a blood sugar test or to check hemoglobin level or thyroid function that we keep repeating it again and again. And it's not something that we do for everybody. It's not like this test has to be done for everyone. We have some criteria to recommend the testing. We generally advise it only for breast cancer patients with one or more blood relatives who are affected with breast or ovarian cancer. This family history is very important. It becomes all the more important if those blood relatives are first degree relatives like siblings or parent. And if they have developed, if the relative has developed breast or ovarian cancer at a young age, that is less than 45 years of age, that raises the suspicion whether this cancer could be genetically driven. So that's how we recommend in those patients. And then we also recommend this testing in families who are known to have BRCA mutation running in their family.
Okay.
And we also recommend it to patients who have developed cancer in both the breasts, either simultaneously or sequentially, or if they've developed both breast and ovarian cancer, either simultaneously or sequentially. And in nowadays, we're recommending it in patients who have a particularly aggressive variety of breast cancer, which is called as the triple negative breast cancer. So once a patient is diagnosed to have a germline BRCA mutation, we then recommend their children and siblings also to be tested. And once we have decided to test an individual, we just do it only once on the blood sample or on the cheek swab sample. Unless the clinical history and the patient profile is very strongly suggesting an inherited genetic defect contributing to higher breast cancer risk, and the test result comes back negative, contrary to our expectation, we generally don't repeat the test. So we can reconfirm it by doing it once more. But a positive test result is not going to change with time, or it's not going to change with any therapy. As I said, it's a germline defect. It's going to be with the individual forever till that individual is alive. So we can probably repeat it just once more to confirm a negative or a positive result, but it's not something that we keep repeating again and again, unlike other genetic tests. So we can just do it once or twice at the most.
Okay. Ma'am, also, can you share some success stories or example where genetic information significantly influenced breast cancer prevention as well as treatment?
Yeah, there are many such examples from our day-to-day practice from our clinic. There are patients in whom, once we've done the genetic testing and they're found to have BRCA1 or BRCA2 mutation, we have counseled them and they have decided to go for surgical removal of both the breasts and both the ovaries. So these are the risk reduction strategies, which are approved strategies to reduce the risk of cancer. And many of these patients, most of them, in fact, are doing well even after 5 years of follow-up. We also have patients in whom we are able to give a tablet. They are called as PARP inhibitors. So this is a drug. It's a medicine which is given to patients, as I said, after their breast cancer treatment is completed, breast or ovarian cancer treatment. We have to give this tablet for 1 year for them, and this has helped in reducing the risk of recurrence in these individuals. So we have a few such patients who have been able to do well with the PARP inhibitor therapy by reducing their risk of recurrence. And there is another patient who has a very strong family history, and we've been following up very closely for more than a decade now. She got diagnosed with breast cancer about 10 years back when she was 38 years old. She had triple negative breast cancer, which is the most aggressive breast cancer type. Her mother and one elder sister also had breast cancer. Because of the strong family history, we did a genetic testing in her, and she tested to have a pathogenic or a harmful BRCA1 gene variant. And now, 10 years later, she has a breast cancer in the opposite breast. And despite strongly counseling for removal of the breast, she was very adamant she wanted to conserve her breast. So she opted for breast conservative surgery at that time as well as now. She is on regular stringent follow-up and on a screening protocol, and she got because of the stringent screening protocol, the present cancer, whatever she got diagnosed, it got diagnosed when it was extremely small because of the screening, where we could do a breast conservative surgery even now, and she could get away with very little treatment even now without even having to use chemotherapy. So these are some of the success stories from genetic testing or analyzing the genetic risk of breast cancer.
Okay. And ma'am, lastly, what role does ongoing genetic research play in shaping our understanding of breast cancer? And with that, the second part of the question, and how can public contribute to these efforts?
The genetic basis of cancer, it's a dynamic field. It's continually evolving. As we gain more and more insights into the genetic basis of cancer, our screening, prevention, and treatment strategies would also evolve, and they would conform to the newly realized information. Now, techniques of performing genetic testing have also evolved with time. We are getting more and more sensitive testing methodologies, and that give us a wealth of genetic information. One of the reasons why India lags behind in research is because the general public are not keen most of the time in participating in it, which is not the case in Western nations. In India, the moment a person hears the word research, they back off and they don't even allow us to touch them or take a sample. So, a simple blood test or cheek swab sample is enough to get genetic information about cancer susceptibility in an individual. So, public can contribute by having a more open mind towards research and by actively participating in it by giving simple samples like blood, which would not affect them much in any way. It's just a 2 ml blood sample, 2 or 3 ml sample that's required. If more people participate, India can generate its own strong genetic database because we are different from Western population. Most of what we are doing today, not only in oncology, but any medical specialty, mostly it's extrapolated from Western data, which is not always right because we are genetically different. Our genetic makeup is completely different. And we can generate our own data only with the cooperation of the population. We are the most populous nation in the world. And imagine the amount of data that can be generated by doing a genetic analysis of our population. It can pave way for great breakthroughs in oncology as well as in other fields.
Of course. So, ma'am, thank you so much, doctor. That was really an insightful session, and I'm sure our viewers gained a lot from this particular discussion, and personally, even I did. So, remember, relevant awareness and save early detection can actually save lives. So, thank you again, doctor, for connecting with us. And with that, I'm signing off. Keep on following our social media pages, and for more information on health and wellness, do subscribe to our channel. Thank you so much, ma'am.
Thank you. Namaste.